Well, thank you. Can everybody hear me okay? Great. So it's good to be here in my hometown of Vancouver, where I learned a lot of these kinds of issues when I was growing up here. And of course, if relapse prevention was a controversial topic, harm reduction is definitely also extremely controversial. And of course, they had a big harm reduction international conference here in Vancouver a couple of years ago. And there are many people, this was an ad that was published in the Vancouver Sun. Harm reduction is a step backwards. At the last World Conference on Drug-Related Issues, drug policy experts from 25 nations agreed that softening of drug policy, commonly termed harm reduction, has been a major failure. They concluded that harm reduction policies increase drug use and crime wherever they are implemented. In Canada today, the harm reductionists have dominated national, provincial, and local drug policy decisions. And it goes on, but their false promises threaten the well-being of our children, plus they're costing Canadians millions of dollars that otherwise would be directed to real health care. And of course, this was paid for by American drug education policy. So there, in the United States, the whole harm reduction movement has been frowned upon, to say the least. Just mentioning the term harm reduction, a lot of people walk out of the room when you start talking about it, because it sort of goes against the classical disease model, which basically says the only way to help people in recovery is maintain total abstinence, and that harm reduction gives people permission to keep using. But of course, here in Vancouver, it's one of the leading cities in North America, probably not one of, but is the leading city in terms of harm reduction policies, setting up the safe injection site for IV drug users, the heroin prescription maintenance program that's been developed, other kinds of approaches. And more recently, we've been working with people in Vancouver at Simon Fraser University to help them develop their Housing First program. This is for chronic public inebriates, giving them a place to live, even though they're still allowed to drink in their housing. So I'm going to talk about that, as well as the kind of work that we've been doing on harm reduction with young heavy drinkers. I think the only way to resolve this harm reduction controversy is to do good studies, show what the results are, and then people can decide whether it's something that could be helpful or not. So we started doing harm reduction with binge drinking college students at the University of Washington. And this program has been evaluated and now has been adopted by many universities and colleges, both in the United States and Canada. So young heavy drinkers, for most people, this is the heaviest drinking period in their life. Most people that drink heavily when they're in their late teens or early 20s kind of mature out of it as they get older. Some continue to drink much more heavily, and that's more of an alcohol dependence problem. But for many people, young people, it's a kind of a transition that they're going through that can be very dangerous in terms of health risks. They have a lot of problems in common, yet are seen as more isolated. The whole issue about development and adulthood. In the United States, as you know, the drinking age now in all 50 states is 21. When I grew up here in Vancouver and went to UBC as an undergraduate, the drinking age was 21 here also. Now, since then, they've reduced it. It's down to 19. And one of the big issues that comes up in a lot of discussions about drinking age is lowering the drinking age more helpful? Does it reduce problems? Some of the concerns by raising the drinking age is that young people that do have drinking problems don't want to go for help because they're afraid that they're going to be accused of criminal activity, underage drinking, so they tend to sort of take their drinking underground, where it's much more difficult to evaluate or assess or get people help. There's lots of problems associated with peer influence, social drinking, impulsivity, and conduct history. Young people with a conduct history problem are much more likely to have alcohol problems as well. And yet most of them don't see drinking as a problem in its own right. So the question is how to work with these people to try and get them some help and to overcome some of the resistances that they might have in terms of seeking treatment. Many of them are probably concerned that treatment would mean abstinence, and so they're not willing to show up. So the spectrum of intervention responses that was developed by the Institute of Medicine suggested that inside that triangle is sort of the population that we're dealing with. Young people, many of them don't have any problems on the left, and mainly we're dealing with primary prevention to try and help people, young kids, not initiate drinking. And then we have people with mild problems and moderate problems. And over on the far right, people with severe alcohol problems are going to be recommended for treatment. But what about in the middle there? People with moderate problems, what about brief interventions? That seems to be one thing that seems to be working and has been done in a number of different settings, not just with young people, but people in trauma centers who are brought in because of car crashes involving drinking or other kinds of things. Brief interventions, meeting with the person for once or twice, talking to them and using a motivational interviewing style, a non-confrontational style, and talking about what kinds of things could be helpful, giving them some choices, has been found in research studies to be very effective. Larry Gentilello was one of the first to do that in Seattle at the Harborview Trauma Center. And now in the United States, all trauma centers are basically saying required to have brief interventions for people that come into their programs in order to get licensed. And more recently, Tom McClellan, who is a psychologist that some of you might know, an expert in alcohol and drug work, and he was appointed to be the Associate New Drug Czar in the United States, said that we're going to train primary healthcare physicians in hospitals to do brief interventions with patients that come in, whatever their co-occurring problem is or medical problem. If alcohol or drugs show up as well, how to do a brief intervention rather than just not doing anything or confronting them so that they don't choose to do anything. So the program that we're going to talk about here, it's, brief interventions, how effective are they? Let's take a look. Now, the National Institute on Alcohol Abuse and Alcoholism published this call to action a couple of years ago saying that college student drinking is a big health problem. In the United States, 1,400 to 1,500 students die every year from alcohol-related problems, car crashes. A lot of them is just over drinking. They just overdose. Turning 21, there's this practice called the 21 birthday thing where you have 21 shots of vodka, in a row, and a lot of people just collapse. In fact, Tom McClellan's son died from an alcohol overdose at his college graduation party. So the whole thing about why aren't we working with these people to keep them alive is really the issue that harm reduction brings up. And there have been other approaches. This was one developed by Wesley Perkins, social norms and the prevention of alcohol misuse. What these programs do is they try and tell students at any particular university what the average drinking rates are. Because they found that most students think that other students drink way more than they do, and that tends to escalate their drinking rates. So if you give them accurate information, how many people drink, how many people don't drink, and what the average number of drinks per occasion would be for incoming freshmen, males and females, doing this seems to bring the drinking rates down. And down here in Bellingham, Washington, at Western Washington University, they have a social norms campaign. So if you go into the cafeteria, you'll see posters, the incoming freshman class, how many people drink, how many people don't drink. So it's all based on surveys, and it's accurate. And since they've been doing that, drinking rates have dropped about a third in Western. So that's very helpful, just giving people accurate information about what the norms are. And then there have been some interactive internet programs. This is Alcohol 101. This takes you to a virtual party. And if you're a student, you can plug in how much people drink and see what happens to them. And you get taught about blood alcohol levels. And there's also a sexual assault segment where people can see what happens if too much alcohol is involved in sexual activity. So it takes about an hour and a half to go through the program. And many people, and we've done this as well at the University of Washington, it's a helpful brief intervention. And it's available online, and if you're interested, you could look it up. But we thought maybe we could develop something more promising in terms of alcohol strategies for students to develop an alcohol skills training program. So this was our first program to teach people safer drinking habits. And we did this at the University of Washington, and we selected students who were basically either picked up in college dorms or at football games or something for being publicly intoxicated and having other problems with alcohol, and also volunteer students to take part in the program. So here's what we do in the alcohol skills training program. It's basically an 8-session program, although we have a briefer version, and this is for groups of students rather than the basics program that I'll mention next, which is a one-on-one intervention. So this is therapists meeting with groups of students, 8 to 10 students at a time, for 8 weeks, training in self-monitoring of blood alcohol levels so they can keep track of how much they've been drinking, teaching them drinking moderation techniques, particularly dealing with situations involving increased risk of heavy drinking. We have a lot of drinking games now, ping pong games and things like that that people tend to do. What if you don't want to get intoxicated? How do you tell your friends about that? And then coping with negative emotional states. Many of the students that we see, when they come in as freshmen, they're new at the university, they don't know very many people, and basically they say, if I want to go out to a party and meet people, I want to drink a lot first, so that I feel more relaxed. And that, of course, when they get to the party, they drink more and they tend much more likely to become overly intoxicated. So how to deal with negative emotional states is part of the program, how to do other ways to relax. Training to recognize and modify alcohol outcome expectancies. People that have very positive expectancies for drinking, it's going to make me more relaxed, it makes me happier, people like me more, tend to drink more than people who have more of a balanced set of expectations. If I drink too much, I might have a blackout, or I might not be able to remember, what happened, or I might not be able to perform very well on the exam. Tend to drink less. So how we modify alcohol expectancies is we bring them into our bar lab, I'll show you in a minute, and give them placebo drinks. So they think are alcohol, but don't have any alcohol in them. And a lot of the times I'll show you what the bar lab looks like. So they're in there and they think they're drinking real drinks with alcohol, even though they're all placebos, and we get a very strong placebo effect. People start to feel much more relaxed, they start talking more, they get louder, and things like that, and then some of them start swaying around. And after about an hour, we say, guess what? There's no alcohol in any of those drinks. And a lot of them are like, what? Come on, So we say, look, when you go drinking, there's 3 things that are going on. What you're drinking, yes, but also the setting that you're in. If you're in a bar and there's music and things like that, that's going to have a big effect. And your expectancies about what is going to happen will influence the placebo effect. And so we've just found that just taking people through one of these placebo drinking trials tends to reduce their drinking about 30 to 40% in follow-up studies. So this was one component that we included in the alcohol skills training program. Then training in alternative stress coping skills, relaxation. We've done a lot of work with meditation with college student drinkers. Tends to significantly reduce their drinking, especially when they're stressed. And exercise, aerobic exercise. Those 2 activities, both, and if you put them together, you get an even bigger effect, tend to significantly reduce drinking rates. And then training in relapse prevention. Once you have a new plan to drink more safely, how do you stay on it, and what happens if you fall off the plan, how to get back on track. So what we found, this is one study looking at 1-year follow-up results after people went through the alcohol skills training program. And what we're looking at here is blood alcohol concentration. So 0.08 is legally intoxicated in Washington State. Is that the same in British Columbia? Anybody? What the legal limit is? 0.5? Okay. Well, in our state, it's 0.08. But you can see before the pre-treatment, the average drinking rates were putting their blood alcohol levels like way above legal intoxication, around 0.12. Now, the other groups that we were comparing our group with, the skills training group, which is on the left in purple, we had an alcohol information school just to give people information about alcohol, but not teach them any new training or coping skills. And then a group that just kept track of their drinking without any intervention. And you can see that all the follow-up points, the only group that kept their blood alcohol level below legal intoxication were people that took the alcohol skills training program. So that program is still being used, And lots of people prefer a group-based program where they're dealing with other people with drinking problems rather than just seeing somebody individually. Now, the BASICS project, BASICS stands for Brief Alcohol Screening and Intervention for College Students. These are all my colleagues at the University of Washington who helped put this together. And we were funded by the National Institute on Alcohol Abuse and Alcoholism. And there's a manual that's available by Guilford Press that tells you how the program works. All the assessment measures are in there. So if you're interested in doing this kind of program, that would be the best resource. Now, the stages of change model, which has been very effective in terms of when to do what in terms of addiction treatment, talks about these different stages of change. I'm sure many of you heard about that. Pre-contemplation is, I don't have a problem. What are you talking about? Contemplation, well, maybe I have a problem, but I'm not sure what to do about it in terms of drinking. And then once you get to the point of preparing to make change and to move into action, then you're kind of moving into developing the plan and trying it out and see if it works in terms of maintenance. If relapse occurs, then of course we use relapse prevention or relapse management to help people get back on track. But most of the people that we're dealing with are in pre-contemplation or contemplation. So how do we do motivational enhancement strategies to get them to the point where they're willing to make an action plan to change? Now this is showing, we did an anonymous questionnaire in the so-called Greek system at our university, fraternity and sorority members who tend to drink the most of anybody, and asking them what kinds of things had happened associated with their drinking in the last 30 days. So it was anonymous. They could fill in whatever what the truth was for themselves. And we can see there was a lot of negative consequences. 40% said they got into fights, acted bad. 40% feeling they needed more alcohol to get the same effect. 36% driving after more than 2 drinks. 36% blackouts. 30% passing out. And then went to work or school high or drunk, 16%. But if you look for the fourth from the bottom there, felt you had a problem with alcohol, only 16% would say that. So I think there's something about admitting that if you're a problem drinker, it puts a lot of stigma, shame, and guilt, and people are not willing to go to treatment because of that. But if you ask them what kind of consequences they're having, they're willing to admit that these kinds of problems do occur. So if we say to them, would you be interested in a program that would reduce the problem consequences? And of course, if you want to quit, we'll help you quit. But if you don't, we'll help you drink in a safer way. Many more people show up for the program when you put it that way, as we'll see. So we did a study, a 4-year outcome study, to do a randomized controlled trial with incoming freshmen to the University of Washington. We have 4,000 freshmen coming in every year. And we sent, once we knew who was accepted, we sent a questionnaire asking them about their drinking and whether they would like to be in the study when they got to the university. And what we were wanting to do was pick the top 20% in terms of their drinking rates in high school before they came to the university. So they were drinking more than 80% of the other participants. And as we'll see, we got over about 54% response rate of people wanting to potentially be in the study. And then they were randomly assigned either to get the BASICS program, it says treatment there, or just kept track of their drinking as the control group. And the first session, we had just met with them twice. So BASICS is a 2 one-hour sessions. The first hour, we give them feedback about their drinking. They filled out a lot of questionnaires. We know about their family histories of alcohol problems, medical problems, psychological problems. So we just give them feedback. Here's what it looks like here in terms of what your risks are. And then the second session, what are you going to do about it? Let's see if we can negotiate an action plan so that you can change your drinking. But we don't tell them what to do. We collaborate with them. We use motivational interviewing so that they're having a lot of input into what the program happens to be. Then it says step care options. So for some students, we found out fairly early that they were just not responding and were getting much more problems with their drinking. So we would recommend outpatient counseling and even residential treatment if necessary. So the step care model, as you know, the first step is do something brief and see if it works. And if it works, great. If not, you've got to, you know, move it up a step. And you keep going until you get something that works. And then we also selected a control sample along the bottom of people that were just normal drinkers, not in the highest 20%, and just did assessments to see how their drinking would change over the 4-year period. So we sent out 4,000 screening questionnaires. We got 54% responding, 25% or 508 were high-risk, identified high-risk drinkers. Of those, 366 agreed to participate. We had 11 clinical cases that needed abstinence-based treatment right away, but we ended up randomly assigning 348 heavy drinkers either to get basics or to be in the assessment-only control group. And then the just normal drinkers, 115 agreed to participate. And we had a number of drinking measures of alcohol consumption, how much they drink, of course, frequency, how often they drink, maximum peak blood alcohol level. We have a daily drinking questionnaire that's very helpful. And even people in the control group who just filled out the daily drinking questionnaire said, that was very helpful, because I never really kept track of my drinking, and now I've got some feedback. And that was a good intervention for many of them. And then we looked at alcohol negative consequences. We used the Rutgers Alcohol Problem Index, similar to what we looked at before. It's looking at things like blackouts and getting into fights. And then we had 2 measures of alcohol dependency. And then we, just to get some collateral verification for each student that was in the study, they were asked to give us the names of 2 close friends who would give us independent reports on the students drinking with their permission. And we found overall about 85% agreement between what the student in the program said and what their friends said about their drinking rates and problems. So in basics, in the first session, we're looking at risks or cues for over-drinking, your friends, how much they drink, the people that you're with, the place where you're drinking. Are you drinking in a situation that could be dangerous? The last death we had at the University of Washington campus, a young woman turned 21 in a dormitory. She wanted to have a party for her friends, many of whom were not 21. So they were afraid of getting caught by the residence hall advisor. So somebody said, where can we go and not get caught? And somebody said, well, there's a balcony on the 7th floor. The advisors never go there. Let's take our liquor up there. So they all went up. There was about 6 of them, and they had a bottle of vodka and rum and so forth. And they tended to want to drink fast because they didn't want to get caught. And the young guy who died, he was sitting on the edge of the balcony on a little railing telling a funny story, and he just lost his balance. Head first, 7 floors down, killed on impact. So where you're drinking is going to be extremely important. And of course, driving or anything like that is all equally prohibited. Also, when you drink, the time in the day, you know, for some students, happy hour starts around 2 o'clock in the afternoon and keeps going for the rest of the day. That's going to make a difference whether you are eating or not, whether you drink before you eat. We tell people if you drink when you eat, your blood alcohol level will still end up at the same level, but it'll take longer to get up there. So eating and drinking tend to be safer than just drinking. And then special situational factors like spring break, that's a huge drinking period for many young students. And then emotional factors, especially self-medication and using alcohol to try and feel better. So we're individualizing this with each student, male or female, what it's like. We have a lot of information from their assessment materials. Now, as you know, motivational interviewing has 5 general principles when we're working with a person. It's a non-confrontational approach. We express empathy, understand what you're going through, but develop a discrepancy. Here's what your drinking is like now. What do you think it would be like if you drank at a more moderate level? Let's see if we can develop a discrepancy between where you are now and where you'd like to be. We don't argue with the students. We roll with the resistance. And anything the student says that might be helpful, we'll support it, support self-efficacy. One sorority gal said, well, in our sorority, we drink Thursday, Friday, Saturday nights. And we drink a lot. And I was thinking maybe not drinking Thursday night. That's a step in the right direction. So we would support that rather than say, no, you shouldn't be drinking that much at all. You know, yes, let's go with that. If the student is in the pre-contemplation stage, they don't see themselves as having any kind of problem, we try and raise doubt about their current behavior, look at the consequences, and get more aware of the risks that are involved. and the problems caused by current behavior. So it's kind of getting people more enlightened about some of the risks. If the student is in the contemplation stage when they come in and we've given them an assessment to find out where they are, then we're just trying to tip the balance between the pros and the cons. Shall I make a change or not? Look at the reasons to change, some of the highlights of not changing, what would happen, and again, strengthening the student's self-efficacy for changing their behavior. So we try and match our intervention to where the student is in the stages of change. In the second session, it's negotiating a plan for change. So we want to set goals about limits about drinking, how much you're going to drink, when are you going to drink, what kinds of situations you're going to drink in and not drink in. What are some options to not drinking, some options to drinking that could be enjoyable otherwise, and coming up with a plan by the end of the hour and writing it down and then encouraging the student to follow the plan. And as we'll see, we do feedback and follow-up so that if they're sticking with the plan, we know that. If they've gone off it, we can talk to them about how to get back on the plan. Now, these are the kinds of, one of the things that we teach the students about the biphasic response to alcohol. Because many people, students feel like that line, that arrow going up on the top there, cultural myth about alcohol. That myth is the more you drink, the more enjoyable it's going to be. The more high you're going to get. That's not how alcohol works. Alcohol does have a euphoric effect when you first start to drink, but if you keep drinking, it moves into a dysphoric effect. So you start having problems with coordination, problems with memory, sexual kinds of problems, and things like that. So what we're asking the students are, what is the point of diminishing returns for you, where one more drink isn't going to make you feel better, it's going to put you in the other direction. And those two lines depends on how much tolerance people have. If people have low tolerance, they tend to have a higher point than if people have higher tolerance and it's a lower point. So what we're basically trying to do is talk about tolerance and differential effects when you're drinking. We also give every student a blood alcohol concentration chart. So this depends on gender and what your weight is. And many students don't realize, for example, that females will get intoxicated more quickly than males, even if they weigh the same, just because of the body fluid weight differentiation between the genders. So this is for a 185-pound male, and what you're looking at there is the number of drinks. And basically, there's almost the same amount of alcohol in a bottle of beer and a 4-ounce glass of wine or a single, ounce of whiskey. So we're asking them to count their drinks and then look at over the time period that they've been drinking to see what their blood alcohol level would be. So we're basically saying keep out of the red range there. So for example, if you have 4 drinks in 1 hour, you'll be legally intoxicated. If you spread 4 drinks over 3 hours, you'll be at 0.03 and so forth. So what we're asking people to do is when you go to the party, make a plan ahead of time, how much you're going to drink over what period of time to keep your blood alcohol level much more moderate and below the intoxication level. And many students find this to be a very helpful assistance. And then in terms of the plan, the action plan to keep track of your drinking, slow down, space your drinks. Many of young people, they drink a couple of beers, they don't feel anything right away, so they go, I'm going to have a couple more. They don't realize that it takes about 30 minutes for one drink to have any effect on your physiology. So if you slow it down, and many people said, I slowed it down and I still feel the effects, so I didn't need to drink anymore. Space your drinks, have non-alcoholic drinks in between, select different types of drinks. One young guy says, well, I don't know exactly how much I drink because in our fraternity we have this strip naked party. We don't really strip, but we all get a little loaded and there's this big barrel and we pour all our alcohol, vodka, wine, beer in there and we mix it up and then we have these big mugs and we drink them. I have no idea how much alcohol I'm drinking. And we go right, this is not going to be very helpful. Select different types of drinks with lower alcohol level, drink more for quality instead of quantity, and learn to enjoy the mild effects. Then we give them graphic feedback. So this is basically every feedback period, we would give them information once we got their drinking levels, and we could see that this particular student changed their drinking rates from about 12 drinks per week down to, per day, down to about 5 drinks. So still drinking quite a bit, but showing a trend in the right direction. If students started to drink more, that would show up in the graph, and then we would try and meet with them to see what was not working and how to get them back on track. So what kind of results? We're looking here at the difference between being in the high school before entering college and the autumn of the college year. The high-risk sample on the right, you can see that their drinking went up even more once they got to college, but the random sample, people not heavy drinkers, also doubled their drinking rates. So going to university in the first year is a very high-risk period for many young people in terms of their drinking rates. So here's what we got, the 4-year outcome results. First, we're looking here at drinking problems on the RAPI scale. Those are the things like getting intoxication, fights, blackouts, and so forth. And you can see that over the 4 years, both the group that got the basics program in the purple there and the high-risk control group reduced their drinking. That's the maturing out effect. So in year 1, most of them are 18 or 19, and then year 2, 20, and then 21, they're legally able to drink, and then the year after. But we did get significant reductions in drinking for people that took the basics course overall, even though both groups were drinking less. And then the green line are the comparison group, people that were not problem drinkers. And you can see that in year 2, when they turned 21, their drinking went up a little bit, but then it went down again. So drinking problems were significantly reduced. We also found changes in drinking rates. They weren't quite as pronounced as drinking problems. Many students said, well, we still like to have our six-pack and so forth, but we don't go driving, we watch the game, and we stay at home. So they're still drinking a fair amount, but their problems are dropping off because of the situational changes that they've been making. So basically, we thought that harm reduction for young heavy drinkers, here we're dealing with college students, but now we're also working with high school students. We've got a lot of input from people in the military that want to do something similar for their populations. It's low threshold. We don't ask people to abstain. If they want to quit, we certainly help them and do relapse prevention with them. We don't use labels. We try and stay away from whether you're a problem drinker or not. We're just looking at your drinking behavior. It's a habit. What kinds of consequences? What kinds of things do you like? What kind of things do you not like? We treat young people as adults. And yes, we do tolerate illegal activity if they're underage drinkers. We're still going to work with them. And we try and tailor it to their personal history and to their risk status. So if all we have is abstinence as a requirement, it's a high threshold route. Young people, at least at my university, say, well, I'm not going to do that. What do I do? So pull down the barrier, have a low threshold route, a harm reduction road, leads to moderation. We still have the possibility of abstinence. So we're not saying it's drinking or not drinking. It's like, what are you going to do now with these problems? And what kinds of things might be helpful down the road a little bit? So the 3 dangerous drives in adolescent motivation, they're all Ds, right? A lot of drinking or drug use, dating and sexual activity, and driving. In the United States, they're still, in terms of dating, saying we should have abstinence-based sexual education programs, because if we teach people about safe sex, they'll do it more. And our harm reduction approach is, look, you've got to teach people these kinds of things anyway, because sooner or later they may end up in a situation where there are going to be a lot of harmful consequences if they don't know what to do. So I think that a harm reduction approach can apply to all 3 of these kinds of approaches, these 3 behaviors. So here's a little questionnaire. Are you a harm reduction therapist? Are you a licensed or certified healthcare provider or work under the supervision of one? Do you provide health services to individuals who suffer from drug-related harm? Are your health services guided by the principles of compassion, engagement, collaboration, self-determination, and pragmatism? Are they ethical, culturally competent, evidence-based, and guided by an assessment of your client's needs, goals, strengths, and resources? And are you willing to deliver low-threshold health services that reduce drug-related harm to clients who are unable or unwilling to stop using and to their loved ones? And if you said yes, then yes, you are. And you could, we're also inviting people to join the Association for Harm Reduction Therapy. So that's what we're getting, and what happened with Basics is it's now listed as an evidence-based practice on the National Registry of Evidence-Based Practices in the United States. So even though it's harm reduction, we don't call it that in the title, has been recognized and accepted as an effective approach. So more and more universities are now doing the Basics program. So I'm going to switch now, just got in the last 15 minutes, to talk about the Housing First project. This is another harm reduction approach, but rather than dealing with college students, we're dealing with homeless alcoholics, chronic public inebriates in Seattle. And the first program that was developed like this to give housing for homeless alcoholics and allow them to drink in the housing was started in Canada. I think it was in Ottawa. And since then, other programs have been started, and there's one in Vancouver now as well that I was mentioning earlier. So let's go into what's going on here and how it works and what kind of results we're getting. So it's low-threshold housing for chronic public inebriates. Now, in King County, that's where Seattle is, there's about 1,000 people or so. It's going up, especially with the economy collapsing, so it's increased. People living in the streets. They're dying at rates greater than other homeless subsets, those who have chronic alcohol problems. The average life expectancy is 46 years old. So lots of people are getting huge medical problems. They're out in the streets. They're dying way earlier than otherwise could be the case. And consuming taxpayer-funded crisis services at elevated rates. So the medical costs and emergency room costs are extremely high for this group. So the crisis services that they frequently use are sobering detox centers, emergency departments and hospitals if they're picked up and something's happening where they need to go to the ER, involuntary treatment, jail time, criminal justice service, 9/11 emergency medical services calls are all costing huge amounts of money. So the Downtown Emergency Services Center in Seattle were the ones who developed this program. It's a nonprofit group. They work with 5,000 plus homeless adults a year. They tend to work with people that are most sick and most vulnerable. And emergency shelter, licensed mental health, and CD services. They want to develop supportive housing and have high level of integration across programs. So they were the ones who basically said, for example, that housing is a basic human right, not a reward for clinical success. So here's this gal lying on the street underneath one of the bridges under I-5, and then what she's like once she has a room. So experienced people want a home to live in and to get better. So the idea is if we can give them a place to live, we're not asking them to be abstinent or otherwise they would get kicked out. And there are some programs like that in New York, in other words. If you're abstinent, you can stay. If you drink, you're out. And of course, 80% of the people start drinking and they get kicked out. Then they don't want any more help. They're just going to go out in the streets. And so getting them a chance to be able to have a place to live might motivate them to drink less and maybe even seek abstinence programs. There was a lot of controversy, of course, when this program opened up because most people said, they're not going to drink less, they're just going to drink more. You're just using taxpayers' money to support their alcoholism. What's going on here? But the principles were to move directly from the street and homelessness into a housing treatment acceptance-based approach, harm reduction, leases and tenant protections under the law continued. So it's called pre-recovering housing for people unable or unwilling to abstain, low demand, flexible structure. They have intensive 24/7 staffing, people to help you. They have medical people as well as regular therapists. The goals overall to reduce the use of alcohol and reduce the use of crisis services. So here's a little sign. It opened in December 23rd, 2005. Welcome home, stay as long as you want. Now how people were selected for the housing was they got a list of King County medical services, how much money each of these people that the services had to pay to keep these people in treatment. So we picked the people right from the top of the list, and either they got housing right away, there were 85 apartments available in the apartment building. Both men and women, it was more about 90% men. And then the other people who were on the wait list for housing were sort of our control group. So eventually that got housing, but we wanted to see what the difference between getting housing right away and not getting housing right away would be. So very controversial. There was a lot of coverage in the media, editorials opposed to the project, a few articles that were favorable, steadfast support by funders, elected officials, and business community, including the chief of police at that time in Seattle, Kurlikowski. He was in support of it. He said, you know, getting these people off the streets may be helpful. And now he's the new drug czar in the United States. So we're hoping that he's going to institute more harm reduction programs than have been available before. Here's some of the articles that appeared in the Seattle Times: wrong time, wrong place. It was opposed. Seattle to build housing for street drunks. Liberal lunacy mandates drunk dorms as a homeless cure. Dumb, really dumb, and so forth. So a huge amount of negative publicity when the place opened up. So the research aims to evaluate the impact of the housing on utilization and cost of public services, and to look at alcohol use outcomes. So we recruited people, as I said, from this high utilizer list, and we made offers, and the 79 first housing offers were extended to fill the first 75 openings. 95 participants enrolled at least 1 year prior to the current analyses, and 68 or 71% of these remained in the house at least 1 year. We used a number of assessment procedures to evaluate medical costs and to look at alcohol use and functioning at baseline, 3, 6, 9, 12, and 18-month follow-ups. So this is basically a fairly mixed ethnic group. A pretty high number of Native participants, as well as African American and Hispanic. And as you can see down at the bottom, most of the participants were men. We just published an article about the women's reactions to being in the housing unit. They liked it on the whole, but you know, being around a lot of intoxicated guys all the time, some of them felt maybe we needed our own apartment just for women. So people are looking at that now. So what kind of results are we getting? First, we're looking at sobering center utilization rates. On the left, that's the intent to treat. These are people still on the streets and hopefully waiting for housing. And then on the right side are people that were housed for a full year. And this basically looks at the reductions in sobering center utilization. So much higher reductions for people that had housing compared to people that were in the wait list. And there was huge savings in terms of sobering center costs. Sobering center costs 1 year prior compared to 1 year post. So the purple thing is how much the cost dropped at the end of the first year for people that were in the housing compared to the intent to treat group. Reductions in shelter visits also were significant. Much less than they were during the 1 year prior to being in the housing. Shelter cost reductions also significantly reduced. Reductions in medical center visits. You can see the 1 year prior, the people that were in the Harborview Medical Center for medical center visits dropped significantly. Also big reductions in medical center costs. So also reductions in emergency medical service calls. Also reductions in costs there. So we can see that each of these different groups are showing significant reductions in costs and visits if they got housed for 1 full year. Also significant reductions in jail bookings for both groups. And jail booking costs were significantly reduced. Reductions in jail days also reduced. And costs of days in jail were reduced. So overall, when we published the results in the Journal of the American Medical Association last May, we basically found that for the 85 participants that were in the housing, the overall savings in medical costs, jail costs, sobering time, and so forth was over $4 million. So basically, once those results came out, people said, hey, this is saving taxpayers' money. It's not increasing, and we'll see, it's not increasing drinking rates. There was pretty stable detox admissions in terms of both groups, so there wasn't really as much change for detox. But here's reductions in drinking in the past 30 days for people that were in the housing unit, compared to drinking in the past 30 days. The blue one is 1 year prior to getting in. So they were showing about 23 intoxicated days out of a month. And once they were in the housing, that dropped to about 12. So they're still drinking a fair amount, but it's much less than it was before they came in. And the number of days of abstinence has gone up a small amount. Now, I must point out that we did not do any harm reduction interventions like the alcohol skills training program with these folks, because the grant that we got said we just want to look at housing itself. But now that we're showing these positive results in terms of reduced medical costs, our new grant is going to be training them to drink more moderately using our alcohol skills training program that we talked about before. And also, many of the residents, I've talked to them, are saying, you know, we've been hearing you're doing this meditation mindfulness work at the university. Why don't you come and teach us some of this mindfulness work? We'd like to do that. So we're developing a comprehensive program to help people reduce their drinking, and also if they want to stop drinking, we have a relapse prevention program for them. So we're basically trying to meet their needs and to work with them in a way to keep them healthier and hopefully keep them alive longer. One thing about harm reduction, whether we're talking about needle exchange programs or whatever, well, maybe you're giving people permission, but on the other hand, we're trying to keep them alive. That's what we're doing here. That's what harm reduction is all about. So limitations of future directions, winding up, findings focus on pre-post changes. The waitlist comparison group enrolled, we're still doing analysis on them since we published the first article. Alcohol use data is based on self-report, so we need more observation like we did with the college students, more collateral reports. Privacy policies serve as barriers to serving CPIs and evaluating outcomes. And future focus on more assertive engagement strategies, harm reduction, to reduce alcohol consumption. So that's what we're getting, and we're collaborating with folks up here at Simon Fraser University to see what they're getting and to compare this. But I think that for homeless alcoholics, given the number of increases that we're seeing across this country and the United States and other places, more harm reduction programs could be helpful. So thank you.